أنا مصطفى، أنا third year pulmonary critical care fellow بفلوريدا، وكمان بعمل lung transplant و ECMO fellowship هلا. نبلش بالحال. هسه في 54-year-old patient عنده AML diagnosed in 2022, failed the first round of chemotherapy, got another round of chemo, failed. So the plan was to proceed with a bone marrow transplant. So he was directly admitted to the hospital, and he received an HLA matched, unrelated donor peripheral blood stem cell transplant. And prior to receiving the transplant, he got conditioning with cyclophosphamide, fludarabine, and he got total body irradiation. That was in April 2023, and من 4 شهور. During his hospital course, he had delayed count recovery, he had pancytopenia, and basically concern for graft failure, graft missing. He required multiple transfusions, and he was requiring, bone marrow stimulating agents pretty irregular. So his current medication, the relevant ones, I think the others I didn't include them because they're not really relevant to this case. But aside from his chemo and everything else he got, he's currently on prophylaxis with antifungal prophylaxis with posaconazole, PGP prophylaxis with pentamidine, monthly pentamidine, herpes prophylaxis with valacyclovir. Well, he's on letermovir. Usually they use Valcyte as first line for both of them, but because he has pancytopenia, he was on letermovir and valacyclovir. Well, at some point, I'll tell you, he had some HHV6 viremia, so instead of these two, he was on foscarnet. He also was on basically immunosuppression for GVHD prophylaxis. He got Cytoxan after the transplant, and he was on Tacro. And just because he had continuous pancytopenia, they held the cell site. So just before digging deeper into our case, let's kind of have an idea about more about stem cell transplant. I didn't know a lot about stem cells transplant until later on in this fellowship. So there's a few nomenclatures, some words that we have to understand to know kind of what we're dealing with. So there's autologous, allogenic, and umbilical bone marrow transplants. So autologous, so it's from the patient himself. You collect the hematopoietic progenitor cells from the patient himself, and then you give him chemotherapy, and you reinfuse these cells. How are they collected? Well, there's different ways. One of them is just accessing the bone marrow directly. However, that's very painful, requires general anesthesia. Now more centers are moving towards just getting the stem cells from the peripheral blood by doing apheresis. And the advantages of autologous, obviously it's the same patient, therefore less chance of rejection. There's no possibility to develop GVHD, less risk of infections to CMV pneumonitis and other opportunistic infections that are usually transmitted from donor to recipient. The allogenic is from a different someone else, obviously not the same patient. And it could be either related or unrelated. If it's related, usually they use a sibling because they have a higher chance of compatibility, around 25%. If it's a parent, the chance of compatibility drops to around 1%. And then it could be unrelated. And if it's unrelated, it's either HLA matched or mismatched. For our patient got an allogenic matched transplant. So he got it from someone else he didn't know, but it was matched. And then there's also the umbilical, which is the cord blood transplant immediately after delivery. You don't have to worry about that so much. Now, the source, as I mentioned, they can either get it peripherally or the bone marrow. One, it's easier to get them peripherally, and more centers are moving towards the peripheral bone marrow stem cell transplant because they have faster engraftment times, so the graft build goes asra, and they have less risk of graft failure. However, they're on the other side, they do have a slightly increased risk of chronic GVHD down the road. So this is basically it. They take the healthy stem cells, they put it back into the patient, and then the hope is that it's going to replace the diseased stem cells. This is the autologous process. They collect the stem cells, they process them, they preserve them, give the patient chemotherapy or high doses of chemotherapy and or radiation, and then they reinfuse the stem cells. The same thing for allogenic. However, instead from the patient himself, it's from a different one. So the transplant process, the 5 main stages, and it's important to understand what happens during each stage, because from a critical care standpoint and also from a pulmonary standpoint, you have to understand what are the possible complications that you might face. So before the stem cell transplant, you have 7 to 10 days of conditioning. And the whole idea of conditioning is basically they destroy the immune system. They give them very high chemotherapies, or they do total body radiation, or sometimes a combination. And the whole idea is to basically eradicate the immune system so that you have the stem cells that you infuse, they're going to have a space to actually go into the bone marrow. That's one. Two, eradicate the immune system to decrease the risk of infection. And three, if it's, for example, for a cancer like AML or so on, is to basically eradicate any residual disease cells. After that, they move on to the actual bone marrow stem cell, and they usually what they do is place a central line, is placed centrally, and they process the stem cells. And the whole idea of processing it is a bit more complicated. However, the idea is to remove as much T cells as possible, some T cells, to decrease the risk of GVHD. And GVHD is where the donor T cells attacks the recipient's body, usually manifests in the lungs, in the GI tract, and so on. And there's different formats, acute and chronic. هذا مش التوبيك تبع presentation اليوم. That's the process. That's why they process the bone marrow before transplanting it. And then the infusion, the things that you have to watch out during infusion is anaphylactic reactions and significant overload. There are some preservatives sometimes used during this processing step that might increase the risk of AKI2. So these are the things you want to watch out for during this period. After that, well, you already eradicated the patient's immune system. However, the stem cells won't start kicking in and working for another 2 to 4 weeks. So you have 2 to 4 weeks in which the patient technically has no bone marrow and has no immune system. So it's the neutropenic phase, and this is the phase that's the highest risk for infections. And we'll go over the different infections that you might be experiencing. After that, around 4 to 5 weeks, if the patient engrafts, so the graft succeeds, it will start working, and then your immune system will start waking up in a way. The risk of infection starts decreasing. However, you're still at risk of the other opportunistic infections because the patient's immunosuppressed to decrease the risk of GVHD. And when the immune system wakes up, you worry about the stem cells that you transplanted start attacking your own body. Again, risk of GVHD, the acute GVHD at that point. Down the road, over months to years, what happens is the body kind of starts getting used to this bone marrow transplant, gets used to the stem cells, so you develop some form of immune tolerance, and therefore, during this immune tolerance phase, you require less immunosuppression. However, at that point, the main thing you gotta watch out for is like the chronic rejection, which is the chronic GVHD in the case of bone marrow. So again, this is going to back to kind of the steps. You have the conditioning chemotherapy. After that, we get the stem cell infusion. Before the stem cell infusion, you start the immune suppressants. This is the maintenance immune suppression, which is usually a combination of tacrolimus, mycophenolate, and steroids too. You have the cytopenic phase, which is around 4 weeks, and then you have the engraftment phase, which is roughly 4 weeks after that. Now, our patients remain in this cytopenic phase, and he never really engrafted. So during his hospitalization, he had continued pancytopenia. He kept having spiking fevers, despite being on broad-spectrum antibiotics, despite significant infectious workup, continued to be negative. He was placed on the big guns, the cefepime, and then at some point meropenem, and then vancomycin, micovungin, and basically he's received a long course of antibiotics, and mixing up between different courses of antibiotics for this neutropenic fever. However, he never went into like progressive shock or anything like that. It was just febrile. He did, however, have an HHV6 viremia. These are routine things that we check in our patients: CMV, EBV, HHV6, almost weekly in these patients. And when your immune system is really low, these viruses kind of act up. That's why you gotta keep an eye on them. And this is what happened. He had HHV6 viremia that was minimal, however, and therefore they started foscarnet right away, and it resolved after 3 weeks. He cleared it after 3 weeks. Now this is where we come in. The patient started having asymptomatic hypoxemia. He started requiring some oxygen, but he didn't really complain with. They got some CT chest initially, and this is on the oncology service. They saw some ground glass, some maybe small effusions. They're like, this is probably all the fluid that we've been giving him with all this chemotherapy. They diuresed him some. However, he did not improve. He kept requiring more oxygen, increased the high flow, and at some point intubation. Now, before he went into the intubation and before high flow, while he's still in nasal cannula, they consulted pulmonary and repeated a CAT scan. And based on the CAT scan that I'll show you now, we decided to proceed with a bronchoscopy. As expected, he did not have any cells. It wasn't even quantified. However, we do get a percentage from the cell diff, even though there's like very minimal cells. irrespective, the cell diff was not very useful. So this is his CAT scan. Anyone wants to jump in and just tell me what they read? It's not the best one because there's a lot of motion artifact, but anyone?
شباب حدا بده يعلق حدا عنده اي انبوت يعني شايفين بايلاترال يمكن جراوند جلاس وباسيتيز
بالضبط يعني هو bilateral diffuse ground glass و airspace disease وجست عشان اريحكم فيش شيء على الميديستاين windows just move on. What are the things we have to think about in these patients that go into respiratory failure from a bone marrow transplant standpoint? Now, in general, in terms of the risk of lung complications post bone marrow transplant, patients that are older and also patients that have pre-existing lung disease, as expected, are at higher risk. It's even to the point that if you do a PFT and their DLC is less than 50%, that might be a contraindication or make him ineligible for transplant. It varies from one transplant center to the other, but it's something they take into consideration. Obviously, infections, and then these, there's obviously some overlap. However, they usually divide into pre-engraftment and post-engraftment. The viruses and the bacteria are the same kind of across the pre and post-engraftment. However, there's increased risk of herpes early on, varicella and CMVs more later on, along with other infections that we'll dig deeper into in a second. So again, other pulmonary BMT complications, aside from, since in the pre-engraftment, we'll go back to before the graft actually بيمسك قبلها بشهر خلال الشهر هذا وبعدين فقبل الشهر you have more neutropenia and therefore you're at higher risk for bacterial or fungal. Aspergillus is the main thing we get concerned about, obviously Candida too, and then all the different types of bacteria and viruses with a higher risk for herpes early on. Now PJP has the sort of and everyone's on prophylaxis. So the risk of PJP prophylaxis is lower compared to how it was before. There's also the risk of disseminated toxo or strongyloides. Now this patient was only on nebulized pentamidine, and that usually covers for PJP, but it doesn't really cover for disseminated toxo. Usually if you use Bactrim, for example, it usually covers for both. Dapsone might cover for both, but or atovaquone, but pentamidine has really no coverage for toxo. احنا كمان عندنا mainly strongyloides is the main parasite here. Other thing you can develop is edema. Edema, they get a lot of blood, they got a lot of units of blood, they get a lot of fluid, and therefore these patients are obviously at higher risk for any pulmonary edema, whether cardiogenic or non-cardiogenic. Some of the chemotherapies can cause cardiotoxicity, so they can also develop like a HFrEF kind of picture. Also, you can develop non-cardiogenic edema from whether radiation, from the chemotherapy itself, and there's also some other processes that we'll talk about in a second. These patients usually specifically during this neutropenic phase, early in the first month, they can have severe mucositis, increasing the risk of aspiration and lipoid pneumonia and aspiration pneumonitis. And then DAH also is quite common, not only because they're pancytopenic, but because they can have inflammatory processes. And the DAH is just a manifestation of different things, whether the infection, engraftment syndrome, GVHD, drug toxicity, things that we'll discuss in a second. And the treatment is usually supportive plus or minus steroids and treating the underlying cause. Still pre-engraftment. Now, this is the syndrome that's kind of specific for bone marrow transplants. You have what's called engraftment syndrome. Basically, significant inflammation, pro-inflammatory state causes an ARDS picture, but they also have fever. They might have a rash, but the rash is not similar to the GVHD rash, and they can also have diarrhea. Again, diagnosis of exclusion, and the treatment is supportive وsteroids. يعني هو ما عندناش غير diuresis, steroids, with antibiotics. For supportive treatment steroids. How much steroids? It really varies. بالآخر سوي كيفك. Whatever seems deemed appropriate. We tend to pulse our patients with a gram a day, and it has pretty significant mortality, around 25%. There's also what's called acute GVHD or hyperacute. Hyperacute usually happens when you have HLA mismatch, which usually we check for before we transplant these patients. So the risk of hyperacute is extremely low. However, acute GVHD might happen, but when acute GVHD happens, it attacks more the GI, system, the skin, and so on, and less likely the lungs. So now moving
مصطفى
on to
يبدو في سؤال على الشات. يبدو في سؤال على الشات.
اوكي. تمام. هلا دخلنا على البوست انجرافمنت. هسه بجاوبه بالشات. هسه بندخل على البوست انجرافمنت اللي هو بعد الشهر. برضه نفس الشيء، الالتهابات البكتيريا هي نفس الاشياء اللي ما قبل وما بعد. في كمان بدخل المايكروبكتيريا زي تي بي وان تي ام. بعدين كمان risk of CMV. CMV بيعلى بعد اول شهر. other viral ال HHV6 زي المريض كان عندنا HHV6 بالبلد not confirmed in the lungs. Herpes, adenovirus and so on also increase after a month. نفس الشيء fungal increasing aspergillus specifically الشيء الوحيد اللي بدك تفكر فيه in these patients. usually ببلش بعد 100 يوم تقريبا متوسط الاسبرجيلس infection toxo reactivation. في كمان syndrome اسمه idiopathic pneumonia syndrome برضه ببلش بعد شهر يعني بالpost engraftment phase و up to 10% of patients can be affected. عادة بصير بعد شهر. الميديان تايم تبعه تقريبا شهرين و up to 4 months. نفس الشيء high risk in allogenic يعني الترانسبلانت اللي من حدا ثاني واكثر من الاوتولوجيس. ونفس الشيء it's like an ARDS picture, widespread alveolar injury, some pneumonia, and basically it's a diagnostic exclusion. So you have these the PERDs which is in the pre-engraftment syndrome and idiopathic pneumonia syndrome هو تقريبا نفس الفكره ARDS picture diagnostic exclusion بس واحد قبل شهر والثاني بعد شهر والعلاج تبعهم الاثنين نفس الشيء supportive therapy وستيرويدز. وما بيعرفوا exactly ايش الباثوجينيسيس بس فكروا انه basically due to certain radiation the chemotherapy they get them can cause pulmonary epithelial injury activate and cause like a inflammatory reaction. But the second one is more fatal, the idiopathic pneumonia syndrome. Despite all the optimal therapy, everything you can do, المورتاليتي يعني 70 من 5 إلى 77 من المرضى اللي بيصيبهم idiopathic pneumonia syndrome بيموتوا. هلا ايش كمان في ممكن المرضى يصيبهم PEP. في الفاسكولار ديزيز like pulmonary hypertension من الكيموثيرابي for example داساتينب اللي بيستخدموه ل certain AMLs can also increase your risk of group 5 PH. والchemicals والradiation نفسهم الكيموثيرابي can also cause pneumonitis and you can also develop is a recurrent AML for example it can also involve the lung. Now in terms of the chronic GVHD هذا مش relevant للcritical care بس relevant للpulmonary is down the road these patients can develop chronic GVHD وعادة بيكون detected on PFT. You have to screen these patients almost annually with a PFT. You start having some airway obstruction and later on the CAT scan you might see some mosaicism and air trapping bronchiectasis at a later stage. وهدول نحطهم عادة على azithro 3 times a week. Singular اللي هو المونتلوكاست و high dose inhaled corticosteroids but all this is based on the data تبعت هاي الأشياء كثير ضعيفة يعني و immunosuppression for chronic GVHD overall. فإحنا based on the time period the patient still very pancytopenic neutropenic obviously infection هو أول إشي كنا بنفكر فيه. Other risks were acute GVHD though less likely. Idiopathic pneumonia syndrome just based on the time وكان البيشنت لأنه عنده bone marrow failure كان ياخذ تقريبا 2-3 units every day. فتاكو or Charlie was the other differential. So عملنا obviously extensive workup, respiratory culture, bacterial, AFB, fungal, respiratory panel, PGP PCR, crypto بالبلد والBAL, aspergillus بالبلد والBAL. HHV6 viremia كان عنده temporary وراحت وما كان في باللنج. الEBV والCMV كانوا نيجاتيف, البارفو نيجاتيف, الادينو نيجاتيف, varicella نيجاتيف, هيستوبلاستو نيجاتيف, اكو نيجاتيف. فقررنا نحط المريض على انتيبيوتكس بروتفاكتم ميرولينيوزيلود ومايكوفنجن دايوريست لانه على اساس انه فلويد والمريض كبير وقلنا left atrial dilation يمكن عنده شويه هفاف. والاتش اتش في 6 لانه كان عنده اتش اتش في 6 ما كناش لسه عارفين اذا في lung involvement فبلشنا ثاني على forced cardiac restart. Unfortunately, his hypoxia worsened. The patient got intubated. Despite optimal ventilation, got paralyzed, proning flowland. Patient went into fluoride ARDS. He kept worsening. Given worsening والnegative infectious workup, إنه خلاص يمكن هذا idiopathic pneumonia syndrome. Let's pulse this patient with steroids. We did pulse him. I'll pause here. أوقف هون نشوف إذا حدا عنده أي سؤال أو أي فكرة عن الموضوع. أي حدا بيحب يرمي differential إشي تاني. إذا حدا كان ممكن يتصرف بطريقة غير. إحنا هيك تصرفنا. هل هذا صح؟ هل هذا غلط؟ شو رأيك؟ طيب هسه المريض بعدها بكام يوم صار عنده ألسر على تمه هيك شكلها. Does that change your mind about what's going on? Does that make you think of something else? المهم احنا فكرنا من necrotic lip lesion herpes. فبعدنا الهربيز طلع عنده positive بالlip lesion وبعدين بعدنا البي ال طلع positive والبلد طلع positive. وهذا despite him being on foscarnet which treats herpes. وقبل الفoscarnet كان على valacyclovir prophylaxis which also prevents technically should decrease your risk of herpes. Irrespective, we decided to treat him with IV acyclovir 10 milligrams per kilograms and high dose. Now the risk of resistance in herpes ما راح أدخل بالديتيلز about herpes بس أحكي أنا هون relevant للكيس تبعنا إنه it is possible for herpes to become resistant to foscarnet in immunocompromised patients. However, ما في يعني a proper test that you can do. You can do a viral culture وبعدين شوف إذا في drug specific testing just for each drug and see if they respond to them. واحنا عندنا بالجامعه ما كانوا يسووا فحتى حكوا حتى لو بنقدر نسوي takes time وانت you guys need a decision now so just treat it as if it's resistant and therefore we kept the patient on the foscarnet for his HHV6 viremia and IV acyclovir for herpes now. Well, the patient went into refractory ARDS and the decision was to put him on ECMO. So the patient راح على الVV ECMO على بعدها بشهرين تقريبا من transplant. So شو الECMO or extracorporeal life support system? Well, they literally what you read. So it's external lungs and or heart, and it can be used either for respiratory failure, heart failure, or a combination of both of them. بالنسبة respiratory failure, usually you put them on VV ECMO. إيش indications? Usually PF ratio less than 80 بس لازم يكون على appropriate mechanic. في حد بيحكي شيء؟
طيب صح؟
SS please pause. Mute sorry.
وين متعلق هاي؟
المهم
شمس
هاي حطها على حيط الجراج.
مش هون.
لا احنا مع الكولكشن اللي برا.
إذا من
دكتور SS مايكك مفتوح لو سمحت تسكره.
فالانديكيشنز الفي في اكمو اللي هي الريسبيراتوري فيلير عندك البي اف ريشيو less than 80 بس يكون على appropriate vent settings يعني مش يكون على بيب اوف 5 وتقول لي البي اف less than 80 وتقول لي بده يكون اكمو. لازم يكون on a decent PEEP و you've tried everything you can do medically يعني you diarised the patient, you've treated whatever the underlying cause is, عملت له paralysis إذا بده paralysis proning و plus or minus flolan أو epoprostenol. Or despite that the patient is still very hypoxic or hypercapnic and you are not able to ventilate them on the ventilator or as a bridge to lung transplant يعني مش شرط يكون شيء acute زي المريض اللي كان عندنا هيك ممكن يكون شيء عنده خلص end stage ILD فهدول البيشنتس ممكن تحطهم مع ECMO إذا المريض أنت شايف إنه down the road is going to be listed for transplant. mean again واحد someone very sick or chronically sick بس ما يكون عنده issue futile يعني ما يكونش عنده metastatic cancer or something that's going to make his case futile. And when do you put them again for acute respiratory failure is if you think إنه المشكلة اللي عنده هتكون إشي temporary وخلال كام أسبوع على الأقصى إنه it's going to be resolved and he's going to go back to his normal lung function, that you're going to be able to take him off the ECMO. امتى تحطه على ECMO? If you're going to put him on ECMO, you should optimally put him on ECMO early on. The study is less than 7 days, or less than 2 days is even the better outcomes. وين مش أي مكان ECMO center، المهم يكون ECMO center عنده شوية experience بالموضوع. that's it. So إيش الإكمو فيه؟ الإكمو فيه عندك كانولاز، واحدة بتسحب دم والثانية بترجع، وعندك بامب بالنص بيشفط من هون بضخ على الأكسجينيتر، والأكسجينيتر وبعدين بيرجع تاني للمريض. إيش الأكسجينيتر؟ اللي هي بسموها الممبرين، هي basically سلندرز طويلة زي هيك كتيرة وبيعدي فيها غاز، وهذا الغاز تتحكم بهاو fast it goes تعدي جوا السلندرز بالسويب. The higher the sweep, the higher the gas flows. And you can see هون تحت على الشمال you have very low, very high oxygen in this gas and technically no carbon dioxide in that gas. وفي البلد اللي حواليه اللي هو الفينس blood اللي انت اخذته من بالكانولا. So you get the blood gets oxygenated and decarboxylated. It works as a lung pretty much, and then it is returned back to the patient. So لازم تتأكد إن الممبرين دائما بيشتغل. فتقريبا على الديلي كورس الدم ما قبل الممبرين وما بعد الممبرين تبعت له ABGs. We have to make sure that الأكسجين بيطلع. شايف كيف الفينس مفروض إنه يكون كتير واطي، بس بعد الممبرين بيعلى كتير لما أكثر من 300، والكربون دايوكسيد بيكون أوطى بكتير. إذا شفت إنه الأكسجين ما عم بيعلى للدرجة اللي أنت حاببها اللي هي أكثر من 300 after the oxygenator membrane، فهذا معناها في عندك شوي في شيء defective بالممبرين itself. بعدين عندك البامب كيف بيتحكم؟ هو basically rotations، بيعمل rotations per minute، و the higher the rotations per minute the more the flow. And the flow usually that you set for the patients is around 3 to 6 liters, and then it depends on the hypoxia too. So cannulas طبعا بيعتمد هل انت بتستخدم VV ولا VA ECMO. هلا بالنسبه للريسبيراتوري فيلر بتستخدم VV ECMO، وللVA ECMO للهارت فيلر بتستخدم الVA ECMO to bypass the heart. الVV ECMO usually the cannulas في different types of cannulas, but usually drain from the venous side, usually placed in the IVC through the femoral vein, and then you return it back into the heart at the level of the right atrium, aiming the jet towards the tricuspid valve. عشان تسحب من ال IVC وترجعه تاني على tricuspid valve into the right side of the lung, and then to go to the lungs and then into the heart. بس بالheart failure or VA you want to bypass the heart completely. ففي either peripheral through the femoral or central, usually post-op بعد العملية بيكون already مفتوح، they can have access directly to the arch of the aorta. They can put the A cannula, arterial cannula in the aorta itself. احنا نركز على شمال لانه هذا الحاله اللي تبعتنا عندنا VV ECMO، واحد عنده حطوا له واحد بالفيمرال وواحد بالاي جي. So this is an example of the different cannulations. على الشمال بتشوف انه في 2 femoral، واحده اقصر توقف بالاي في سي والثانيه بتضلها طالعه لفوق، which is not again a typical configuration though it is used. بس the typical is what you see on the right. في كانولا فوق بالاي جي اللي هي return cannula، والدرينج كانولا اللي هي بالاي في سي اللي بتسحب تحت بتوقف. في كمان different forms of VV ECMO. في كمان إيش اسمه Protect Duo. So the VV ECMO في كانولا واحدة زي هاي اللي على الشمال هلا بتشوفوا، في عندها side port وفي عندها distal end. الديستال end بيوقف بالاي في سي، هذا بيشفط، والside port هو اللي aim towards the tricuspid valve. ف basically one cannula in the IJ بيعمل شغل 2 cannulas dual lumen. في اسمه Protect Duo زي هذا اللي على اليمين. basically هذا you can see it goes extends into the PA. نفس فكرة السنجل كانولا، بس instead of it ending at the level of the right atrium اللي هي الديستال end، الديستال end تبع هذا بيكون بالpulmonary artery، فبشفط من الرايت atrium وبضخ بالPA. You bypass the right side of the heart basically. So شو الeffects تبع الأكمو? Obviously oxygenation, carbon dioxide removal, but other things, it has impact on the pulmonary mechanics and the hemodynamic mechanics. So from an oxygenation standpoint, the oxygenation, usually the sweep gas اللي بيعدي بالcylinders تبع الممبرين بيكون 100% oxygen, and انت بتتحكم بالاكسجينيشن تبع المريض based on الفلو تبع الأكمو in relation to the cardiac output of the patient. هون طلع اليمين graph, as you can see, as the ratio of the flow, يعني flow عالي بالنسبة للcardiac output, you have more oxygenation. إذا الفلو أوطى يبقى you have less oxygenation. ليش ليش الفكرة؟ ليش طب هلا احنا بنرجع المريض 400 الارتيريال اكسجين بيطلع من الاكسجينيتر 400 بس لما تشيك بالمريض بيكون مثلا 90 ولا 100. ليش هيك؟ well the whole idea is انت بالكانولاز اللي عندك ما عم تشفط قاعد كل الدم اللي موجود، انت بتشفط نسبة معينة من الدم ولسه في deoxygenated venous blood bypass. So whatever you return is mixing with whatever the venous blood that's still not sucked into the machine, and then that's what you see in بالمريض. يعني هذا اللي انت بتفحصه بالمريض. فبالاخر ما بتلاقي المريض عنده 400 arterial oxygen و CO2 30، يكون شيء بين البينين. فباسically الفكره انه بالاكمو the higher the flow the more oxygen delivery. Patient hypoxic علي الفلو. هلا بالكربون دايوكسيد كيف بنشال؟ هلا الكربون دايوكسيد it diffuses much faster على بالممبرين than the oxygen, and therefore the limiting factor مش blood flow, it's mainly the how fast you sweep the gas. كيف الجاس اللي انت بتضلك تبدله قديش السرعه تبعته. بس 10 liters per minute, therefore you have more carbon dioxide removal. And that means the patient is not doing well because he needs a lot of support from the ECMO. So higher flows, higher sweep equals more support equals the patient is not doing very well. At the to the point a type of ECMO called ECOR, which is basically a low flow, high sweep system. Since we're not dependent on flow for removing carbon dioxide, low flow is acceptable. وهدول مثلا البيشنتس ستاتس asthmaticus اللي خلص you cannot ventilate them, instead of putting them on VV ECMO you can just put them on ECO, for example. Now in terms of the data and how good ECOR is, I mean the data is still not great. بس هون كمان نشوف على اليمين as the sweep gas flow decreases your carbon dioxide increases والعكس. أما the sweep does not affect the arterial oxygen. طب ايش الامباكت on respiratory mechanics؟ هلا انت طالما you're doing the work of the lungs يبقى انت بتقدر تريح اللنجز، فبتحطهم على rest settings بالفنتيليتر، بتحطه على pressure control 10/10 respiratory rate of 10. ف you have lower respiratory rate. المريض كمان doesn't trigger as much respiratory rate. He doesn't have to. The tidal volumes are lower, and therefore the plateaus and the driving pressures are lower, and therefore you decrease the risk of ventilator induced lung injury. ECMO can be so useful to the point إنه خلص the patient can even be extubated even though his lungs are still not doing well, and therefore if you don't have a ventilator كمان the risk of failure is even lower. ايش الامباكت على الهيموداينامكس؟ RV unloading. هلا انت when you improve, as you can see on the right, as oxygen improves, carbon dioxide goes down. You can see the mean pulmonary artery pressure بنزل مع الوقت, so the pulmonary vascular resistance goes down. So hypoxemia triggers PE vasoconstriction. You don't have that anymore, therefore you have better flow through the RV, and therefore the risk of right. Yeah. Yes. Yeah, one. فعندك pulmonary artery pressure decrease PVR, improved RV. The main thing in patients with severe ARDS, they go into right-sided heart failure quite frequently, and therefore you're improving the overall hemodynamics of patients. So again, ECMO is usually a bridge, whether acute or chronic respiratory failure, either to recovery, is is going to recover in a few weeks. If not, you want to make sure he's probably going to be a lung transplant or heart transplant down the road if it's VA ECMO. And the third option is until you make a decision whether he will be recover or be a transplant candidate. But this is not preferred. It's always better to make that decision either before you put the patient on ECMO. You don't want to be in a situation where the patient's on ECMO, he's not recovering, and at the same time is not a transplant candidate, well, then you have to withdraw care. So نرجع تاني للمريض البيشنت على البي بي اكمو بالفيمورال اي جي، كان على certain flow، كان على certain sweep. اخذوا له chest x-ray الصبح، بعديها المريض decided الاكسجين arterial oxygen نزل، الساتوريشن نزل للو 80s، فاوتوماتيكلي زي ما حكينا الفلو، علي الفلو عشان تعلي الاكسجينيشن. اما لما علوا الفلو شافوا ان الاكسجينيشن نزل اكثر. هذا عنده فكره ايش قاعد بيصير. هسه الصوره اللي على الشمال هي التيبكال صوره اللي انت المفروض تشوفها. طبعا هذا مش البيشنت تبعنا، هذا جست واحده ماخذه من الانترنت. الفكره انه عندك اوكسجينيتد بلاد اللي على اليمين بالصوره الشمال اللي هو الكانولا اللي على اليمين، والدي اوكسجينيتد اللي هو الدم الغامق. So you can see a discrepancy between the venous and the return cannulas. اما على اليمين اللي هو كيف كان مريضنا، ما في difference، الاثنين نفس اللون. فهذا شيء اسمه recirculation. اللي بصير انه الاوكسجينيتد بلاد اللي انت بترجعه للمريض is sucked back بالكانولا اللي انت كنت حاططها to drainage canal اللي انت بتسحب منها دم اصلا. فبيسكلي الدم ما عم بيروح على المريض، بس عم يضل يلف ويدور بالسيركت تبعك. فليش هذا صار عندنا بالمريض تبعنا؟ مينلي لانه عملوا اكس راي، فلما اكس راي بحركوا المريض ايش صار؟ الكانولز قربوا على بعض، صار عندك شيء بروسس اسمه ريسيركيليشن. another idea ليش لما الفلو علي البيشنت صار هايبوكسيك اكثر؟ لانك انت عليت الفلو، عليت الار بي ام، صرت تعلي نسبه السكشن والريسيركيليشن. وثالث شيء اللي بيعلي النسبه انه هذا الشيء يصير، يعني حتى لو الكانولز مش كثير قراب على بعض، بس في عندك ستيسس او باك اب لانه الهارت is not pumping well, therefore you have increased risk of recirculation. شو بتسوي؟ you examine the blood cannula colors زي ما شفنا earlier، وبتجيب 3 gases، واحد pre-membrane، واحد post-membrane، and then one in the patient himself. and ايش اللي بتلاقيه؟ انه البري اللي هو الفينس بلاد تبع المريض عنده الاكسجين اعلى من المريض نفسه، فهذا مش منطقي. فايش ممكن تسوي؟ طبعا تعدل مكان البوزيشن تبع الكانولز، بتخفف الار بي امز والفلو، واذا كان عنده heart failure او congestion او so on you treat his low cardiac output. Now these patients are very high risk for RV failure. ليش؟ لانك انت you're dumping a lot of blood at very high flows into the right ventricle, and with time this RV might not be able to tolerate. So احنا حتى we monitor the almost weekly echoes. طبعا غير bedside echoes اللي نسويها regularly. We monitor weekly echoes for RV failure. So المريض recirculation addressed, they pulled the cannulas، بس despite that لسه hypoxic. فليش hypoxic وايش ممكن نسوي؟ one is increase the flow. طب ايش لو انت limited بالفلو based on the cannula size؟ فايش ممكن تسوي؟ تعلي الكانولا size او تزود كانولا ثاني، تخفف الريسيركيليشن. وبعدين ثالث شيء remember هاي ايام الجامعه delivery of oxygen بيعتمد على cardiac output والهيموجلوبين. Usually we aim, typically in critical care world, we aim for hemoglobin 78. That's not the case in patients with ECMO. It's a completely different patient population. These patients are very hypoxic. Therefore, if you want to improve their oxygen delivery, you might want to aim for a higher hemoglobin. Is there a specific number? No, but just like something more than 7. And then if the ECMO is not good enough, maybe optimize his lung function. And lastly, something you want to avoid is decrease oxygen demand by sedating and paralyzing. You know, the whole idea of putting someone on ECMO is shift earlier to just hopefully extubate the patient so that they can rehab, so they can actually do their own airway clearance and so on. So you want to avoid excessive sedation and paralysis as much as possible, especially if the patient is going to be a transplant candidate down the road. فالمريض المهم صار ظبطنا الاكسجينيشن كل شيء. المريض صار few days later turned off sedation ويصحوه يعملوا sedation عادي. المريض ما عم بيصحى poor mental status. فاحنا كان عندنا two thoughts. one عنده herpes المريض، ليش ما يكون عنده herpes encephalitis؟ المشكلة عنده significant thrombocytopenia وانتيكواجلي، ما كانش انتيكواجلي بس عنده significant thrombocytopenia، وقلنا it won't change management. The main differential is herpes encephalitis. Other differential, the patient is on ECMO, so the patient can stroke out. So we did get a CT head, and he unfortunately had intracranial hemorrhage and subarachnoid hemorrhage. But moving on to ECMO complications. Now, bleeding is very common. Around 25%, 50% من المرضى they can have bleeding, and it could usually major. And ايش factors that play a role? Well, one, the patients usually on ECMO are anticoagulated. I'll tell you why in a second. The ECMO machine تاكل البليتلتس أكل والفبرينوجين والفالفولنرين factor, and therefore يعني في basic الفبرينوجين والفالفولنرين factor بيلزقوا على التيوبينج سيستم تبع البيشنت. This leads to some micro clots. These micro clots lead to platelets holding on to these areas. فبصير عندك more clotting, and therefore عشان هيك بيعملوا anticoagulation to decrease the risk of clotting. But at the same time الماشين اللي بتاكل البليتلتس والفالفولنرين factor والفبرينوجين تبعك والpatients on anticoagulation. So risk of bleeding is pretty high. Well, bleeding is associated with worse mortality, more bleeding, more mortality. Every unit of blood increases your risk of mortality by 3%. So نرجع تاني للمشكلة. Bleed or not to clot. فليش لازم نحط المرضى على anticoagulation؟ أنت عندك tubes وعندك machines، كل هاي الأشياء ما عندها endothelium، ما عندها protective factor تبع endothelium, and therefore there's a very high risk for fibrinogen to deposit, the von factor to deposit, for platelets to adhere to these areas, for clots to happen in the machine, and for clots to happen in the patient too. This also triggers hemolysis in platelets, clots, along with the very high flow from the ECMO machine equals hemolysis. And hemolysis also is in a way increases the risk of coagulation. وكمان المريض might be in DIC for whatever reason, other حسب ايش السيتويشن تبعه. وعندك كانولاز كمان، الكانولاز ضخمه جوا الفينز ولا جوا الارتريز، ف you can easily clot either in the patient or in the machine itself. عشان هيك you have to anticoagulate these patients. ف DVT risk بال VV وال VA ECMO up to 50 to 70% يعني من المرضى، يعني تقريبا ما في حدا ما عنده clots بال VV ECMO، وأبطأ بال VA ECMO 30 ل 40%. كل ما يكون الكانال أكبر أو ديول لومن، لأنه ديول لومن أكبر الريسك اوف كلوتينج بيكون اعلى كمان. الريسك اوف بي اي كمان is there لانه عندهم دي في تيز، بس الديفرنت الريسك تبع البي اي مش زي الريسك تبع الاي ار دي اس، انه هو 8 to 16%. It's not significantly higher. طبعا هسه اذا كان عنده VA ECMO, any small clot in this can go into the systemic circulation will go either stroke out or cause mesenteric ischemia, and اذا صار عنده mesenteric ischemia almost 100% mortality. وممكن يكون عندك embolic stroke اذا كان بالفي ECMO انت اوريدي جوا الفي بالارتيريال سايد، سبيشلي لو سنتر اللي حطه بالاورتا اني سمول كلوت بتروح على البرين خلص embolic stroke. والفي ECMO برضه لو عندك شيء اسمه paradoxic اللي هو البارادوكسيكال a right to left shunt whether PF4 ASD او شيء زي هيك. والديستال لم اسكيميا كمان بالفي ECMO لو كان محطوط peripherally او كان في centrally والكلوت ارتمت وراحت على الديستال. So that's why you really we always, if we can, prefer to anticoagulate these patients. The risk of that is higher. I mean, you can stop anticoagulation, you can treat bleeding, but if you have a clot that goes to the brain or to the mesentery or the limbs, you're going to lose these. So that risk, in a way, outweighs the benefit of anticoagulation outweighs that risk. But this is a situation you have to reevaluate daily and the benefit or risk of anticoagulation. ليش كمان انتي كواجليت الاكسجين ممكن يصير كلوتس بالماشين. هسه الماشين البامب ممكن فجأة it fails من الكلوتينج. الاكسجينيتر نفسه هذا اللي removes carbon dioxide و gives oxygenation برضه can develop clots ويبطل يزبط، والكانولا نفسها ممكن get obstructed. شو بنستخدم عادة؟ Well, there's يعني two schools, so again not based on any good evidence, but there's some biological plausibility to using direct thrombin inhibitors. The unfractionated heparin, obviously most common, cheaper, عنده reversal agent, we can monitor it specifically. المشكلة إنه you need antithrombin for heparin to work. والمشكلة in patients that are on ECMO, their overall antithrombin is made in the liver. Its production is limited compared to how much heparin you are using in these ECMO, هدول ECMO patients مرات بيكونوا months on ECMO, months of heparin continuously. Therefore, the amount of antithrombin cannot compensate for the amount of anticoagulation required. And therefore, إذا ما في antithrombin, you develop a form of heparin resistance. وطبعا the most important thing, other second thing, اللي هو HIT. In these patients, we're always thinking about HIT because all of them have thrombocytopenia. وال40 score المشكلة is useless in this patient population لأنه these الماشين لحالها بتاكل البليتلتس. فأنت whether it's all ECMO ولا it's HIT وكمان الماشين كمان also increases your risk of increases your risk of clotting. So عندك risk of clotting وعندك risk of thrombocytopenia. فأنت ال40 score already صار مليون قبل ما تعمل أي شيء. Does that mean everyone really has HIT? No, but this really complicates the matter because if you use 40 بيكون عندك عالي والoptical densities is very sensitive, it's not very specific, very commonly ممكن يطلع لك intermediate فأنت يعني تصير مش عارف شو بدك تسوي. To avoid the risk of heparin resistance from lack of antithrombin, to avoid the risk of HIT, there is also direct thrombin inhibitors like argatroban and bival. هدول بدهمش antithrombin they're shorter half-life they do not cause HIT. بس المشكلة إنه ما عندهم reversal agent. والبايفال is renally clear. That's why إذا واحد عنده renal dysfunction half-life تبعه بصير أعلى. وإذا argatroban is hepatically metabolized. If someone has hepatic dysfunction, argatroban half-life أعلى. طب شو في أوقات ما ممكن تعمل pause للانتيكواجوليشن او تقرر ما تعمل انتيكواجوليشن؟ يس. مريضنا مثلا best example عنده intracranial hemorrhage وسباركنويد وكان اصلا عنده significant thrombocytopenia وهو صار معاه هيك حتى من غير ما احنا نحطه anticoagulation. هو من الاول كان decided ان this patient would not go on anticoagulation. any high risk bleeding you obviously have to hold anticoagulation. around the procedure واحد لسه طالع من big surgery or big bleeding surgery, then you might want to consider before anticoagulating. ايش ال situations اللي هي it's very okay to hold the anticoagulation. VV ECMO عادي جدا to hold anticoagulation if you think the risk of bleeding is high طالما ما عندك مشاكل بالسيركت وما في significant DVTs. We monitor them routinely for any DVTs by the way. It's very okay to hold anticoagulation in these patients. Second of all إذا راح توقف الانتيكواجوليشن تأكد إنه الفلو ضله عالي لأنه lower flows equals stasis equals more clotting. VA ECMO we usually as much as possible always want to keep anticoagulation unless في شيء مصيبة. لأنه أي small clot بالVA ECMO circuit especially لو كانت central equals clot is equals stroke equals mesenteric ischemia equals limb ischemia. شو كمان complications اللي هم strokes والهemorrhage والسيجر والبرين وديث هذول بنحكيهم بعدين. وطبعا infection والinfection risk بيعلى as long as the longer the run. إذا الكانولا بقى لها فترة طويلة as more than 12 days تقريبا بيطلع ل 100% risk. وطبعا the risk of VAP. These patients are intubated for a while. They're not clearing their lungs. The risk of infection is on high. other machine complications الاكسجينير بيفشل الهيموليسيس البامب فيلير والكانلز بتتحرك والسيركت رابتشر. طيب نرجع للمريض الثاني. اللي حكينا هيموليسيس is part of the process انه ممكن يصير هيموليسيس من الاكمو فاحنا we monitor free hemoglobin daily on these patients. So فجأة كان undetectable لا صار in the thousands the free hemoglobin. So basically patient عم يصير hemolysis. ليش عم يصير hemolysis؟ Basically السيركت الفورس تبع الشير فورس تبعت الهاي فلوز تبعت الفلو بالسيستم بالذات لو في كلات مثلا that causes turbulence in the flow هذا increases your risk of the red blood cells mechanical lysis lysis. ففي process ثاني equals اللي هو sharing just for time basically we'll ignore it for now. But basically, a turbulence in the flow, which is quite common in the patient, because في cannulas, في machine, في so on, increases your risk of hemolysis. So شو بتسوي لهالمرضى؟ You maintain the flow عالي عشان ما يكون to decrease the risk of stasis and clotting. Anticoagulate them لأنه clots equals more hemolysis. replace the circuit هذا last resort. واخر شيء اللي هو اخر resort despite changing the circuit اللي هو we plasma freeze the patient. Unfortunately despite all this طبعا ما فيش complication ما صابت المريض بس كان الاهل مصرين انه keep doing everything. بس بالاخر يعني ضرب القاضي كان patient went into hemorrhagic shock massively transfused. والسي تي شاف انه عنده basically عنده هيموبروتينيوم فاخذوه السيرجري وشافوا عنده سبلينيك هايلم والانتيريور افولجن واكتيف بليدنج. عملوا له سبلينكتومي وباكينج واخذوه كذا يوم على المستشفى على الاو ار على الفاضي. بالاخر they withdrew care and the patient passed away. هلا ليش صار splenic rupture؟ one is probably because of the patient had splenomegaly in the setting of previously AML. In the setting of ECMO the risk of bleeding is a bit higher. وفي thoughts يعني you're throwing it حتى في واحد يكتب case report إنه basically GM-CSF causes can increase your risk of splenic rupture and the patient was getting اللي هو bone marrow stimulating factor almost daily to twice a day. بس وهي الحاجة.